harnessing data to give all communities a fighting chance to conquer COVID-19. We've seen and heard stories of physicians, nurses, and many other healthcare heroes stepping up to save lives of patients battling COVID-19. To what extent, though, can proper patient data collection help long-term efforts in identifying critical factors that impact certain populations more than others? Today we'll learn how focusing on diversity and inclusion can help close gaps in health disparities, giving everyone a better chance at overcoming a public health crisis. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hederle, Senior Writer with AHA. In this conversation, Elisa Aris-Pacochaga, Vice President of the AHA's Physician Alliance and Interim Executive Lead for the AHA's Institute for Diversity and Health Equity, talks with two health system chief diversity officers about their efforts to learn more about the patients they're serving through REaL data collection, stratification, and utilization. We'll learn about REaL data and how it may present a clearer overall picture of the pandemic's impact on specific communities. More information is available at www.ifdhe.aha.org.
Welcome to Advancing Health. Today I'm pleased to be joined by Institute for Diversity and Health Equity board member Juana Slade, who is the Chief Diversity Officer and Director of Language Services at ANMED Health in Anderson, South Carolina, and Anton Gunn, Chief Diversity Officer at the Medical University of South Carolina. Thanks for joining me today to share your insights. Undoubtedly, this year has been a whirlwind for those in healthcare, with the rise in response to the novel coronavirus creating many challenges. Leading in this time requires empathy, education, an element of advocacy, and more than a little bit of flexibility. I'm so glad you are both able to join us. Let's start with a little bit about your role and your organization. Juana, you want to kick us off?
Absolutely. First of all, let me say thanks for the opportunity. Thanks for the invitation to talk a little bit about what's been my life's work for the better part of the last 2 decades. I have been a part of ANMED Health since the inception of our then diversity strategy. So I joined the organization in 2001. I have had the good fortune of working for individuals as a part of this organization who were both philosophically and, quite frankly, tactically committed to diversity. And now they have grown over the years with me, and we understand the importance of diversity, health equity, and inclusion, that this is a three-legged stool. One cannot be missing. We certainly can't have that stool without either of those three legs apparent and firmly planted. So I'm in a good environment, if you will. We have good ground here at ANMED Health. Not that we get it right all the time, and not that we are above reproach, because anytime you have people involved, there will always be opportunity for error and mistake. But one of the things about this organization, we seem to be willing to have crucial, meaningful conversations that will result in strategies and supporting tactics that work. One of the things, and I heard my friend Anton reference this a few months ago, anytime you've been in an organization longer than 10 years, you're doing one of two things. You are repeating the successes of the past decade, or you're avoiding the mistakes of the past 10 years. And so that's a double portion for me since I've been here as long as I have been.
That's wonderful. It sounds like you've got quite a history with ANMED and a lot of great work that's been done. Anton, tell us a little bit about your role.
Yes, so very similar to Juana's, but mine is a much later journey. MUSC hasn't really been on the road for diversity and inclusion as long as ANMED has. We had a strategic plan for diversity and inclusion approved by our Board of Trustees in 2013, late 2013. And I was hired in the summer of 2014 and really started in January. So for the last 5 years, I've led not only our Office of Diversity and Inclusion, but I also have a secondary title, and my title is Executive Director of Community Health Innovation, because one of the things that MUSC has made the bridge around is that we can't just do diversity and inclusion within the four walls of the institution. We have to understand the broader scope of the challenge in the community, and how do we target our programs and activities to be able to have an impact outside of the four walls of the institution, because it helps to minimize the negative impact that happens inside the four walls. So for me, this has been a great journey, a great opportunity to really create an Office of Diversity and Inclusion. I'm the inaugural diversity officer, the first person to have any title and formal responsibility to do so. And our CEO, Pat Cawley, when he hired me, he basically said, this is so important. I want somebody to be thinking about this 24 hours a day, 7 days a week, and seeing my blind spots that I don't see. And as a part of our strategic plan and our whole focus, diversity is one of our values at our organization. Our values are compassion, teamwork, diversity, accountability, and innovation. And as you see, diversity is right in the center, and it's not happenstance that it's right there in the middle, but it's intentional around how we provide care for our patients, families, and visitors in our broader community, but more importantly, who are we as an institution? And that is what I'm pleased to help them drive towards and try to evaluate. So that's what I do, and it covers a broad scope.
Wonderful. And I think I'm hearing from both of you that what falls into the duties as Chief Diversity Officer is not entirely focused just on in the organization. It's really, you're really looking at all of the drivers around health and equity and all of the things that could be affected, everything you can see that you can help your organization move forward. So how are your Chief Diversity Officer colleagues and others really using this opportunity to reframe and refocus the conversation around health and equities? Anton?
So I would say I haven't had the opportunity to reframe anything. I mean, this COVID crisis has put a lot of stuff on the front burner, if you will, because, again, I remember talking to one of our leaders and basically hearing the data reports around who is in our ICU and knowing that all of the patients that we had at that day and time that was in our ICU on a ventilator from COVID were African American, all of them. And two of them were in the same family. And so it was real crystal clear on the point in minds of these physician leaders that this is a disparity, that they've never had something to look this way before. So it gave us the opportunity to really think about what are we doing to mitigate this being the case, and how are we able to provide care in a way that would long-term mitigate this level of disparity. And so people have been very open and very transparent about it. And as a matter of fact, in the midst of COVID-19, this kind of environment, after a conversation with our CEO, he basically said, I want to reframe the priorities of our health system. And the third pillar of that reframe was that it is our responsibility to protect vulnerable populations. And so that was his whole mantra, to not just about delivering care inpatient, but how do we protect vulnerable populations in communities? So for me, this has been a great opportunity to talk about the social determinants of health. I can even give you some other standpoints a little later about our scarce resource policy and how I serve on the allocation of scarce resource policy committee and have been ramming up social determinants of health and how we think about who is worthy or not worthy of getting a scarce resource when we have a limited supply left. And so this has given me the opportunity to actually go into spaces and have conversations with things that we've always talked about, but to talk about it in a much more intentional way to make sure that we have an equitable framework, a fair and just framework for how we do what we do.
I think COVID has given us the opportunity to accelerate some conversations. And Juana, what's been your experience?
Well, very similar. I think that the most significant difference, if there is one, is that unlike Anton's, I'm in a part of South Carolina that does not have the same level of diversity among its population. We are one of the smaller counties in the state. Our population is somewhere in the neighborhood of 200,000 individuals, but when it comes to the demographic makeup of our population, African Americans comprise only 13% of the population in Anderson County. And so in terms of the numbers, the sheer numbers in Charleston, they're greater. There is a much greater African American population presence in Charleston. Am I correct, Anton?
Yes.
I think that the challenge, however, is to recognize that COVID-19 presents the same challenge in Anderson County as it does in Charleston, as it does in larger population centers. So it doesn't matter. COVID has had no respect of county size or population density. Those numbers, they understand the impact of using the limited resources, individuals who understand how important it is to be able to have culturally and linguistically appropriate conversations that are rooted and grounded in the ability to make sound decisions is going to certainly require us to be able to look through a very clear diversity and cultural competency lens. So I think that the role that I play in the organization, as I've said for quite some time, is to serve as a chief collaborative officer. Many of the responsibilities that my colleagues have, without their support, without the resources allotted to them, allotted to their areas of responsibility, I would not be able to be nearly as effective, and I wouldn't have the access that I do have. So I think it's important to remember that the impact of COVID has given us the opportunity to engage individuals in this conversation across our enterprise. And organizations across the country are having the same sense of reality, but the challenge is if they have not done the homework, if the culture and the environment is not ready for the kinds of reactions and allocations of resources, it will be even more challenging because we are actually talking about people's lives at the end of the day.
And to that point, I'm going to probe a little bit because I understand that a lot of the work that you're able to do is really supplemented by really having the data. I know that things like collecting and stratifying race, ethnicity, and language data helps to inform the work and helps to educate your entire collaborative team on where you need to focus and where you need to do the work. Can you talk a little bit about how you've been doing that at ANMED, Juana?
We were very fortunate to have access to a care management system called Midas Plus Care Management. And this system originally was designed to help care teams utilize appropriately resources and develop what's called work-focused studies to identify a problem, apply solutions, and collect the information so that you can adjust as necessary. We were the first in the Midas Plus network to use this platform to manage, collect, and analyze language of preference data. Having been at the forefront of analyzing language preference data, providing the level of cultural competency training that would allow our registration staff, our physician network, front office personnel, the individuals in our emergency departments, allowing them to understand culturally how to engage and collect accurate information. It allows our physicians and scientists to take confidence in the information that we collect. And that's the main thing about the collection of race, ethnicity, and language preference data. It's not so much that we have the systems and the capacity to collect the information, but the question becomes, can those individuals take confidence? Can the resources, can the information stand up to the scrutiny of analysis so that as we make decisions about interventions, as they make decisions about care, as they make decisions, we make decisions around resources, we have sound information to help us or to inform that decision-making process. So again, much like diversity in general, the good thing is that we have been at this for a long time. The better thing is that we are willing to figure out what has worked well, where we need to improve, and where we have some opportunities to, most importantly, improve the quality of care that we provide. We can only make those decisions based on sound, reliable data. So real data is at the core, I believe, of what we do and how we have to do it, and that data must be valid.
Now, Anton, you had mentioned that you've been very involved in the strategic planning in your organization. And I know we've heard challenges that some organizations have had in taking that real data and really understanding how to apply it, how to stratify it, how to interpret it so that you can actually move from a bunch of information to some specific actions. What advice would you give to organizations that are struggling to understand how to do that?
For organizations who are struggling, as a part of their strategic planning process to figure out how to analyze the real data that they are collecting, I would advise you to avail yourself to some experts in this space. You may already have them in your organization. I think a lot of chief diversity officers can be helpful in this way, but you may need to bring in other people who can help you to understand what you're looking at, because you can't fix what's wrong until you know what's wrong, and you can't apply a strategy until you understand what you're trying to reach in terms of a long-term goal. So my thing is always to seek out the expertise. If you don't have the expertise, the worst thing you can do is to be afraid of having expertise to help you. I have a philosophy: if I'm the smartest person in my group, then I need a new group.
I agree.
I think a lot of this also requires that collaboration you talked about, Juana, and that internal support from leadership. I'd like both of you to comment on this. What were some of the tools and skills that were most useful to you as you built some of those relationships? Juana, you just referred to yourself as the Chief Collaboration Officer, so let's start with you.
We formed our own internal health equity coalition. And I've got to have the support of scientists. I've got to have the support of clinicians. I've got to have the support of individuals who operate in that space, who are called, trained, and prepared to provide patient care and to take care of patients. So on this coalition, we have those entities that has come to understand over the last several years are important strategically to us. So in turn, we formed a coalition of individuals who could bring those talents and skills to the table to help us look for opportunities, look at the prevalence of disease across demographic groups, find the opportunities to improve health outcomes for those particular identified groups, and then more importantly, make sure, as Anton referenced several minutes ago, we've got to make sure that we have the voices of the community involved in the process. And so this Health Equity Coalition has spent the better part of the last 2 years understanding how we can improve health outcomes for identified patient populations based on the kind of inclusive and diverse environment that we have created.
Anton, what are those key tools or skills you use that helped you build those internal connections?
This is a great question, and I'm going to just be Juana knows that I don't sugarcoat much. Business skills are probably the most important thing that I use to build internal relationships. And what do I mean business skills? We all know that there are two people inside of every health system who have a lot of cachet and have a lot of sway, because whether you're a for-profit or a nonprofit, your whole point is to exist so you can stay in business to take care of the patients and the families in your community. And so we all know the CFO matters in every organization. They count the beans that come in the door. And then the quality team is also important because they're focused on the quality, but they know if we don't have high quality, that's going to hurt the reimbursement rates for everything that we get. So my business skill was how do I understand what's important to those two people first and foremost? Because if I can understand what matters to them, everybody else in the organization is responding to them. So at my organization, it really didn't start with race. It didn't start with ethnicity. It didn't even start with gender. It started with what was happening to the veterans population that we were serving. And again, the second context around skills that I use is after identifying what's important to people, you got to help them to solve their problems. If you want people to help you to solve your problems, you got to help them to solve their problems. And that's what a collaboration person does. Collaboration is how can we have a partnership together to make sure that we both get what we want done mutually in a way that benefits the organization and the people that we serve.
So to wrap up this discussion, which has just been so valuable, this is a question I always like to ask. If you could go back in time and share with your earlier in your career self rather than younger self, let's just say earlier in your career, if you could go back and just give one or two pieces of advice that you think might save you some time and effort, what would that be? Anton, we'll start with you.
If I was able to go back in time and share a couple key insights with my younger self, the first thing that I would say is go faster. And the reason why I say go faster is that when I arrived in my organization, I was very intentional with taking the time to learn the culture. And it took me about 7 months before I asked for anything. And my point about going faster is you got to ask for things if you want to make progress. And many times we put ourselves in a box where we expect to be told no, so we tell ourselves no before we even ask the question. And I think that's a failure of a lot of us, is that we assume that we're going to get told no. And I waited a little longer to ask any questions. And when I finally asked the questions of what I wanted and what I needed, I got told yes by everybody. And had I just asked in the very beginning, I would have gotten told yes sooner. And literally, I would say first and foremost, always ask the question, go a little faster, and don't expect to be told no. I think the last thing that I'll say about my younger self is that I would say take care of yourself. And I haven't had any kind of major health challenge or anything, but I think when you're doing diversity and inclusion and equity work, it is consuming. It is very consuming. It's very important to us. We're not just in it for the job. This is like ministry or a passion for a lot of us. And sometimes we don't take enough time for ourselves. We don't take breaks. We don't take days off. We work over weekends. We're always reading something. We don't have any casual reading lists. We're always reading something about equity or health disparities and how do we apply it to our daily lives. And so my context would be to my younger self, which is, take a break sometimes and find an outlet and have a good, strong work-life balance. And I think that's what I would say to myself if I was talking to myself 10, 15, 20 years ago.
Anton, I'm feeling very seen right now. I'm going to take all of your advice. Juana, what advice would you pass on?
Well, again, as the runway on my career shortens, my list is probably much longer than three, but I will share the top three. And the first one is, Juana, it's going to work out. I was very impatient early on. I was extremely suspicious early on. And so it was very difficult for me to actually believe that I was in an environment that would allow me to do what I wanted to do, what I felt called to do, what I thought was important. I didn't trust that it was going to work out. Well, here I am almost 20 years later, and in fact, it has worked out. I would encourage Juana to create that safe place sooner. Sooner or later, there will be relationships and people who are in the struggle, who are in the work, who are supporting the work, who believe the work, who are called to the work, just like I am. So again, back to that issue of professional trust. And then the last item, kind of similar to Anton's comment, take advantage of the platform sooner.
Absolutely. Thank you both for all that you do in your organizations and the amazing commitment you have to advancing health in America. I really appreciate all your insights, and you're taking the time to help the field continue to advance diversity and inclusion.
Thank you for having me.
Thank you.